Dr. Armin Schwarzbach. Dr. Armin Schwarzbach she's finished between 1984 and 1989 biochemistry in Höchst. 86-91 development of the first worldwide radioimmunoassay for the human gastric inhibitory polypeptide. 1991-1993 assisted in telemedicine, oncology, infectiology, cardiology, and gastroenterology. 1993-2006 specialist for laboratory medicine, infectiology, and microbiology, immunology, and clinical chemistry. And in 2006 and now, it's co-founder and the CEO of the Borreliosis Center in Augsburg, Germany, first European Center for tick-borne diseases, and head of the laboratory and chief physician. Armin, you have the floor.
Thank you. Buna Zioa, ladies and gentlemen. Thank you. I will give my best in my presentation. Thank you for the invitation here. I want to talk with you about diagnostic novelties of chronic Lyme and neuroborreliosis. Borrelia burgdorferi is named the chameleon of symptoms, the chameleon of the antigens, the chameleon of the laboratory tests, the chameleon of therapies. We have actually a completely wrong diagnostic strategy. This strategy came from the USA. It's a two-tier test system. You all know in the first step we have to do the ELISA. The ELISA is paid by the social health system and not the immunoplot. The immunoplot is the confirmation test. But we found out, and not just our group, other groups found out that the immunoplot is more sensitive than the ELISA. That means a more specific test is also more sensitive. What does that mean? That means for you everywhere that we have a high risk cases of positive immunoplots and negative ELISA. And this is a practical example I could show you. I see it each week, each day. We have completely false positive IgG, IgM ELISA test system, and the plots are full of bands. The question is why? So the next step for me was to compare some test producers. I compared the test producers Esculap, Virion, Iazorin, and Autoimmune. And I found out that the sensitivity of the ELISA technique was several test producers, several sensitivity data, up to 42%. That means 60% of all patients are misdiagnosed by wrong negative ELISA test systems from several test producers. You see that this Iazorin was just 32% sensitivity data, and this is very, very weak sensitivity. The next question was about the antibody constellations in chronic Lyme disease. I'm just speaking about chronic Lyme disease. I'm not discussing acute or stage 1 of Lyme disease. And I found out that 40% don't have any antibodies by immunoplot also. 28% have an IgG rest titer, 22% an IgM and IgG persistence, and 10% an isolated IgM persistence. And I'm not the only group in this scientific world, so it's another group from Poland. They did a presentation and a paper about the case of ELISA positive or borderline results observed in only 53% of all their patients. Another study was from Czechoslovakia. 32 patients had specific anti-borrelial antibodies confirmed by using the Western blot. In spite of negative ELISA, in patients with persisting difficulties, it is necessary to use the Western blot test, the postulation by this group. It is probably due to a very low production of specific antibodies caused also by the status of immune deficiencies detected in all of our patients. That means the patients develop immune deficiencies, secondary subclass deficiencies that cannot produce any antibodies any longer. Next problem. The number of IgM and or IgG positive ELISA results range from 34 to 59%, nearly my data. The comparison of immunoblots yielded large difference in inter-test agreement. Remarkably, some immunoblot gave positive results in samples that had been tested negative by all 8 ELISAs. That's a study from January. So what about literature? This literature is not in the guidelines. There's a lot of literature about Borrelia antibodies by ELISA and immunoblots, and evidence-based literature about false seronegativity. That means you have a lot of chronic Lyme patients without any antibodies. There's a lot of studies and papers about this. A lot of studies and papers about this. A lot of studies and papers about this. And what about the isolated IgM persistence in chronic Lyme disease? I told you about 10% around. There are a few studies, not so many studies, but I could present you 4 studies for IgM persistence in chronic Lyme disease. So what about the practical work we are doing each day in the hospital? I want to present you a case report. A 43-year-old patient. She had since May 2005 persistent paresthesia of the left leg, 80% blindness of the left eye, progredient myalgia, recurrent dizziness, substantial loss of power during work, and the threat of occupation disability. The first appointment in my laboratory was in October 2005. The spinal fluid and laboratory tests were all negative, no antibodies in the spinal fluid, no chronic IgG synthesis in form of oligoclonal bands, and all antibody tests, IgM, IgG, by immunoblot, all were completely negative, and the diagnosis at that point of time was multiple sclerosis for this patient, and this patient was treated by corticosteroids, and she was worsening from day by day. And at this time, it's now 7 years ago, I had contact to a new test system, and this is named the lymphocyte transformation test, and the CD57 count, and the lymphocyte transformation test was highly active in this patient's case, and the CD57 count was low. Nowadays I would say this is a chronic inflammation by Borrelia burgdorferi, chronic persistent inflammation, no antibody immune response by IgG and IgM immunoblot. This patient was treated with ceftriaxone, rosifin, and 8 weeks after the end of therapy, this patient was completely healed. The multiple sclerosis was completely away till nowadays. And what you see in this case report, the OSPC, the LTT, and the P18, P100 antigen all were normalized, and this patient was fine. So the correct diagnosis in my case afterwards was a chronic neuroborreliosis with multiple sclerosis-like symptoms, nothing else. And what about this chronic neuroborreliosis and the spinal fluid? We heard some minutes ago that spinal fluid is proving anything, the IgG or IgM is proving anything in chronic Lyme. No, this is not the case. We have enough literature, evidence-based literature about false negativity in the spinal fluid in chronic Lyme disease, not acute Lyme disease. So what about now the B cells, the antibodies? You all have seen immunoblots, I hope so. The immunoblots, we do specific or maybe unspecific bands, and very important nowadays is to do in the immunoblot the VLSE, because this is highly associated with an in vivo activity of Borrelia burgdorferi. We use in our laboratory the immunoblot by Euroimmun, it's a German producer. We have a very high specificity, up to 95, up to 100% of this immunoblot technique. And we use a combination in this test system. It's a commercial test system, recombinant antigens and native antigens. And the problem is, for me, not the specificity of the antibodies. The problem is always the sensitivity in chronic Lyme disease. And I'm a fan, or I do a lot of this LTT test for patients worldwide. And this LTT test is a modern T-cellular test. Some of you have heard about this. And the LTT test reflects the actual T-cellular activity of Lyme disease or other diseases or viruses. And it has been approved by the FDA in May 2011 for Mycobacterium tuberculosis. It's not the gold standard, but it's nearby the gold standard. And in this paper of the FDA, you could read the sentence just back. A positive result suggests that an infection is likely, so okay, it's not proving an infection, but a negative result suggests that an infection is unlikely. And another advantage, the results can be available within 24 hours. And this is another brand new study from Professor Skogman from Sweden. He did a study, brand new, for Borrelia antibody positive asymptomatic children and children with previous clinical Lyme borreliosis and controls. And the blood samples were exactly analyzed by the standardized CE-certified ELISpot technique, and he found no significant differences in the cytokine secretion between the groups. This means, if you want to think about this point, 100% specificity of the ELISpot technique. But you all know mathematically it's not possible to get or to reach 100% specificity of any test system. These are some patients at our hospital where we looked before and after treatment for this activity by the LTT, and what you see is significant reduction when the patient, they have treatments, and you can correlate it in a, we name it a staging process, with chronic activity or actual chronic activity for Lyme disease. And always the question, how evidence-based is it new or is a test system? We have some literature about the LTT, the lymphocyte transformation test, and more is coming. There's a brand new study from Professor von Beer from Berlin. It's a brand new study from this month. It's not in my papers, but I will put it in too. What about the CD57 count that was discussed before? The CD57 count is part of natural killer cells. There are just a few studies about it by Ray Stricker from San Francisco and colleagues, and we see the CD57 count as a chronic inflammation marker. Maybe it's not high specific for Lyme disease, but we see it very often, very low in chronic Lyme patients. So we have a little bit of literature about this, but studies are not so well done in this field. So what is my consequence for practical doctors working in this field with chronic Lyme disease? We should screen each patient by immunoblot, inclusive VLSE, not ELISA. We should do or could do the ELISpot technique. We could do the CD57 count, the natural killer cells, and we could look for autoimmune disorders. Many patients, they develop ANA titers, para-infectious, and you have to control this. What about the immunoassays? I don't know, I cannot answer you. What about the PCR? PCR is a complicated field. We send some samples to Hygienics, to USA. They do a special multiplex technique. It's around 60% sensitivity, but it's not excluding Lyme disease if you don't have a positive PCR in the blood. And where I want to go with you is control the patient. Don't send the patient away after 2 weeks therapies. You have to stage a patient, like in each infection you have. If you have a staphylococcus infection, you have to stage a patient. Control a patient, like in HIV, hepatitis B patient. Do a staging process with the patient. That means control the pathologic parameters and control the symptoms of the patient, and then you have a better outcome for the patient. And what about this big field of co-infections? It's always a question, what is the co-infection of which bacteria? I cannot answer you, but we name them co-infections. It's Babesia, it's Bartonella, it's Ehrlichia anaplasma, it's my favorite chlamydia, it's Rickettsia, Coxiella, and it's Mycoplasma and many viruses. So the road is very long. You could put Yersinia, Salmonella all into this whole diagnostic tool, but this depends on the symptoms. My actual favorite, where I look more and more for, is Chlamydia pneumoniae. Chlamydia pneumoniae is an intracellular airborne infection, human to human. The question is, could it be in the ticks? Mycoplasma pneumoniae is found in the ticks by studies. Or could it be reactivated in Lyme disease? I don't know the answer. The veterinarians are looking for horses, koalas, frogs, and they are all chronically infected by Chlamydia pneumoniae. What about the symptomatology? What about symptoms? You have cough, sorry to go back. You have to have cough, you have a slight throat pain, hoarseness, sinusitis. You could have atypical pneumonia, meningoencephalitis, and so on. But what is very interesting for me, or where I was very surprised, We have a lot of literature about chlamydia and the associations with Alzheimer's disease, multiple sclerosis, depressions, fibromyalgia, chronic fatigue syndrome, heart attacks, acute ischemic strokes, atherosclerosis, autism, Parkinsonism, rheumatoid arthritis. There is big scientific work on it in whole Europe, by veterinarians, by humans. And for me the question always is it very often to suffer from chlamydia and maybe Borrelia, or is it just one problem with chlamydia? So I did a lot of results for this chlamydia pneumoniae. We always do this lymphocyte transformation test, the ELISpot, and we do a lot of IgA and the IgG. And there's a new study for the IgA in acute ischemic strokes. In 60.8%, there is a seropositivity of IgA in adults with acute ischemic strokes. It's a case-controlled study, what makes it very interesting for me. And then the next question is, what about symptoms, symptomatology? Very, very interesting field. We developed then a co-infection checklist for the patient, and this is a case report 2. This was a patient with a lack of concentration, memory disturbance, forgetfulness, painful joints, general aches and pains, heart problems, cough, headache, fatigue, exhaustion, muscle pain, shivering. And then we did a ranking, a score by a score system, and we found out 8 symptoms were speaking for a chlamydia pneumoniae infection. 7 symptoms on position 2 for mycoplasma infection. 6 symptoms for Ehrlichia infection, and so on and so on. And then you got a ranking by this very easy tool coming from the symptoms. And then we did the laboratory test corresponding to that, and to see that there were no antibodies for IgG, IgM, but we had a very high activity in this ELISpot. We had a low CD57 count, a minimal chronic activity, and we had a chlamydia IgA production and an activity in this ELISpot for chlamydia, and also for Ehrlichia. And this patient, interestingly, had a development of ANA, that means anti-nuclear antibodies. So this patient had a multiple infection, not just one infection, several infections, because the symptoms are similar. You cannot say, is this symptom is chlamydia, is this symptom Borrelia? You cannot decide it by asking the patient. So you come by the combination of symptoms, you have a predictive value of the symptoms. And then this patient, I sent the blood to Igenix, Palo Alto, and really this patient was positive by this multiplex PCR, independent from my laboratory, for Borrelia burgdorferi. So that was, let's say, proven chronic Lyme disease, Lyme infection, by several tests, and we cannot do more actually laboratory. Then the last question for me, the correlation of modern laboratory tests for Borrelia burgdorferi and chlamydia pneumoniae. I did a lot of data for this, and I found that chlamydia pneumoniae in our chronic Lyme patients, 60% had an IgA production and 60% IgG production, 67% had a very high ELISpot T-cellular immune reaction. Borrelia burgdorferi sensitivity of the ELISpot was 76% in this group, of the IgM, IgG immunoplot 60%, and CD7 count was 56%. That means actually we have to do many tests to come behind the diagnosis in laboratory, because this is a chameleon and very, very difficult to catch. But what is the therapeutic consequence now? We have several antibiotics, so if you have multiple infection by Borrelia, chlamydia and mycoplasma, you have to go another way than to use ceftriaxone, which is just extracellular working. And typical antibiotics for the intracellular bacteria are the macrolides and doxycycline, tetracyclines, metronidazole, and intracellular working are also plaquenil and artemisinin. And now my summary and conclusions. In all of the studies I did, the sensitivity of ELISA in chronic Lyme disease was just 32 to 42% depending on the test producer. The sensitivity of the immunoplot in chronic Lyme disease was 60%. The ELISA tests are actually too insensitive and useless. The negative antibodies in the immunoplot cannot exclude Lyme disease, not possible. and IgM antibody persistence is a sign for chronic Lyme disease. There is a possibility for false negative chronic spinal fluid results. 86% of our patients with chronic Lyme disease are co-infected or maybe vice versa with chlamydia pneumoniae. The word is multiple infections. Borrelia or chlamydia mycoplasma pneumonia symptoms are not high specific. The symptoms are overlapping. Patients can be co-infected by other bacteria in the tick, Babesia, Bartonella, Rickettsia, Ehrlichia, Anaplasma. You could do a ranking of the co-infections by a modern co-infection checklist. You should stage a patient for Lyme disease and co-infections by modern laboratory tests like the recombinant Borrelia immunoplots, like the ELISpot, like the CD7 count to reach a higher test sensitivity by test combination before you do any antibiotic or other therapeutic decision. Modern laboratory tests like the more sensitive Borrelia immunoplot, non-ELISA, chlamydia, IgA, IgG ELISA, CD7 count, ELISpot could be done in a test package because of a high prevalence of all infections in the population. The ELISpot LTT is recommended by the CDC actually. Infected patients can evolve disorders like AMA, CCP antibodies, or secondary immune deficiencies with no antibodies. And thank you very much.
Now we ask Dr. Carsten Nicolaus to present some data linked to the standards therapeutic. Sorry? Again. With the both, yes. Dr. Nicolaus Klaus is a medical and executive director of PCA Clinic in Augsburg, Germany, founded in 2006. Besides primary health care, he expanded his practice focused by the following areas: tick-borne diseases, geriatric medicine, diagnosis and treatment of vascular diseases, trained as qualified dermatologist, pain therapy in the general practice, complementary by acupuncture and neural therapy, orthomolecular medicine and preventive medicine. Please.
Thank you very much. Ladies and gentlemen, it's a great honor for me to talk today here in Bucharest. It's my first day in Romania, and I appreciate this very much. My 2 days aim is to give you additional information about about chronic Lyme disease, and in the following slides I want to explain my suggestions. So we have heard from a former presenter that Lyme disease is an infectious disease. The pathogen is Borrelia burgdorferi. The vectors are ticks, Ixodes, retinous ticks, mainly here in Europe. Some other ticks are also found, so-called dermacenter ticks, which are more and more common here in your region and now moving to the northern parts of Germany. At the beginning of my presentation, I want to show you some suggestion of an American colleague, which has unfortunately passed some years ago, Dr. Edwin Masters, an American infectologist, and I think he had given a good summary about the problems of this controversial discussion of chronic Lyme disease. So at Masters, I've done a lot of research and publishing studies, which will be shown later on in one of my slides. On the next slide, I want to give you my suggestion about a definition of chronic Lyme. So chronic Lyme disease describes the state of patient with positive tick anamnesis, tick bite or erythema migrans, or the exposition to ticks without recollection of a tick bite, with seropositive blood findings, for example, positive ELISA and or Western blot testing, or the seronegative findings, then including positive findings in ELISpot testing or CD57 testing, if the specific clinical symptoms have persisted for longer than 6 months. These symptoms can also include the confirmed skin signs, state after erythema migrans, lymphocytoma, acrodermatitis, chronic hypertrophicans, or many of the following symptoms are also found. So some orthopedic symptoms like joint ache, pain, swelling, muscle pain. So in example, Lyme arthritis is very often seen. Cardiovascular symptoms as irregular heartbeats, conduction defects or blocks, or carditis, neurological problems that have been mentioned in the former presentation before, psychiatric symptoms and complaints. Fatigue is mostly seen in patients with chronic Lyme, and many other symptoms as well. So the role of co-infection, Dr. Schwarzbach tried to explain. So in my experience, all cases in patients having chronic Lyme disease, they have always additionally some other co-infections as well. So, so from my side of view, chronic Lyme disease means not only a mono infection only with Borrelia bacteria. So very often we see some additionally co-infection. So we differ between two groups of co-infection. One group is only transmitted with a tick bite, like Ehrlichia anaplasma infections, Babesia, Bartonella, or the rickettsial infection, which we know Mycoplasma have been also found in ticks, and a lot of viruses as well are widespread in ticks. So many of these co-infection and Borrelia as well is able to suppress the immune system and or cause a non-specific stimulation of the immune system, leading to inflammation, immune dysfunction and hormonal dysregulation, and autonomic nerve system dysfunction, which had been shown in the mentioned study. And we see very often in patients with chronic Lyme disease and co-infection the persistence of these bacteria despite seemingly adequate courses of antibiotics, and it may be transmitted transplant-centrally, that is also sometimes seen. So from my side of view, chronic Lyme disease is a multi-system illness, better named as a multiple chronic infectious disease syndrome, which we see according to chronic Borrelia and other infection in patients who are suffering additionally from chronic fatigue, myalgias, arthralgias, neuropathic and neuropsychiatric abnormalities. All these patients have multiple overlapping etiologies responsible for their symptoms. So, so on the way, what should be done for diagnostic? So it's extremely necessary to collect all the needed information by anamnesis. Additionally, examinations and testings are needed, like laboratory testing in the way we got the information before. Additionally, some physical and technical examination, and sometimes a very specific examination as well, like MRI or SPECT examinations. So we used an extended anamnesis protocol, a so-called checklist and a questionnaire, to get all the needed information about the general condition of the patient, and on the other hand, symptoms and complaints which are placed in different areas of the organism. The reason why we do so is that we had recognized over the year that there are specific patterns in patients. So I would say 70% of the patients with suspected or later on confirmed Lyme disease have additionally symptoms, very often fatigue, for example, and some of the other mentioned complaints before. Additionally, we try to get first information about these possible co-infections. We always ask our patient to mark one of these co-infection lists, even to get the needed information which co-infection could be seen in them, and to save cost, avoiding other lab testing. So I can forward a little bit because that had been presented in the former 2 presentation as well. So for the lab testing, we also recommend to do beside the serological testings, additionally the cellular testing like ELISpot, lymphocyte transformation testing or CD57 is needed, also PCR testings as well. Beside Lyme disease, we recommend to check on possible bacterial co-infection. The first one are only transmitted by tick bites. Some others could be found by other transmission ways. Additionally, checking for parasites, that is more and more common. I think the new data from the past 2 years have been shown that there's an increasing problem additionally with some other tick-borne transmitted diseases, especially Babesia infection and Bartonella infection. So now it is estimated and for some countries confirmed that in around 30% of the tick you have now the chance to confirm Bartonella infection in many European countries. The viral infection we should also check, because sometimes in getting the information that these viruses could be active, it's a question later on for treatment decision, maybe to make a trial additionally or instead of with antivirus medication. And it's always necessary before doing any decision to check on differential diagnosis. That means to confirm or to exclude rheumatic diseases, autoimmune diseases, inflammation, toxicity, endocrine dysfunction. There could be also a lot of influence from these patterns on them. So I'm not talking about stage 1 infection, not talking about stage 2. I'm also only talking today about stage 3, the chronic organ manifestation or chronic or late stage Lyme. So here some typical slides for the safe signs confirming Lyme disease as erythema migrans in different forms, lymphocytoma. Then it's very common in men in mammals, for example, or in the scrotal region. In stage 2, sometimes we had seen also some single cases in stage 3 with facial paralysis, Bell's palsy. And a very common finding in our patients is the existence of acrodermatitis chronica atrophicans, as you could see in this fact. And we also see very often cases of Lyme arthritis in our patients. So diagnostic requirements. So that is also important information. You know, there are always some completely different illnesses, as for example multiple sclerosis. If you see atypical findings and non-reaction on treatment, think about a possible chronic form of neuroborreliosis that are only single cases, not in general. Don't misunderstand my suggestions. Fibromyalgia, in around 70% of the patient, you can find antibodies for Borrelia in blood testing. So atypical. So the influence of these chronic infections on other psychiatric illnesses is well proven, and so depression is also sometimes found in patients, and atypical forms of dementia, unexplained joint pain such as rheumatism or fibromyalgia. There should be also detected if needed on possible infection. So don't misunderstand, that is not guilty for all patients. Only if you recognize untypical forms with bad response on treatment, think about other options or unexplained neurological symptoms and so on. So So it is evident that there's always a controversial discussion about the existence of chronic Lyme. And so mainly we have two different standards of care. So one is based on the IDSA guidelines and in some countries the national guidelines, for example, neurological, from the neurologist, from the rheumatologist. So that is guilty for many of the European countries. And the main difference between both opinions is seen on the next slide. There's no big difference between stage 1 and stage 2 between both groups, but the main difference is for the existence of chronic Lyme. So mostly IDSA-based guidelines deny the existence of chronic Lyme. They talk mostly about post-Lyme symptoms, so that are non-specific reaction after treatment. And the other group is believing or confirming that chronic Lyme diseases exist. The other big difference is the treatment. So IDSA-based guidelines do not recommend long-term treatment or the other kinds of treatment because it's not existent, and the other group is treating patients sometimes for longer time periods with long-term treatment of antibiotics and additional treatments. So there had been a lot of literature, evidence-based studies and so on, showing that there's definitely in the moment no good testing for Lyme disease, and so very often we see false negative results in the ELISA testing because of the two-tier testing method. And due to all these reasons, we would say that it is more important to be focused on the clinical science, and very often Lyme disease is clinical diagnosis. So having these typical skin signs in acute stages, in chronic stages, all these mentioned symptoms. And if you see a lot of Lyme patients, and we have pre-selected patients in our clinic, then you will see a specific pattern of combination of all these symptoms, and then it's much easier to find the diagnosis. So one of the important questions is, does chronic Lyme really exist? So there have been some other studies showing the persistence of Lyme bacteria in different parts of human organisms. So there have been evidence for persistence in the fibroblast shown by Klempner. In the eye, different part of the eyes the study has been done by triagnostics. Ligamentous tissue could be very often affected with Borrelia, and joints and the central nervous system as well. So there are some good studies for the evidence. Chronic and a lot of literature for the chronic persistent infection, despite intensive antibiotic trials. So it's not possible to discuss all the mentioned studies, but I think it's necessary to prevent all these things to confirm the persistence. So. The following slide is very interesting. After short-term treatment, that patient very often had persistence of symptoms. So that had been shown from Rakova in 2004. She had shown that antibiotics are only successful in 50% of the cases. Kaiser in the same year had also shown that 12 months after treatment, 39% of the patient was acute, but only 20% with chronic neuroborreliosis were acute. And Shattuck, for example, from 69 patients from 184 treated patients reported relapses later on. And a lot of additional studies as well. So another interesting situation is the evidence of persistent infection in other studies. So if Borrelia was cultured from skin in the study from Breyer, so Oxy had shown that 40% of the patient had relapses and so on. So a lot of studies, and I do not want to explain all of them. So the next question is, does longer antibiotic treatment help in persistent Lyme disease? There have been also some interesting studies. So in 1999, Oxy had shown that patients with chronic Lyme had been treated for 3 months with orals or IV treatment. 9 of them relapsed subsequently. So there was a good response to the retreatment with IV ceftriax, and similar experiences had been shown in the study from Donta and later on as well. So I have a problem with my presentation. There's missing the reference list. So that been a study from a very famous American infectologist, Professor Sam Donta, with long-term treatment with tetracycline. After 2 months treatment with tetracycline, 33% of the patient had shown good improvement. In extension of the treatment for 3 months, the success rate improved up on 61%. So another interesting study had been done by Wahlberg in 100 patients with late-stage Lyme and with Fallon. That is also a very well-known study. So in summary for long-term treatment, so due to our experience, we always combine the antibiotics to address all 3 forms, all known forms of Borrelia bacteria, and that is secondly to the ability of the organism to shift between different forms. Some of them go dormant and evade immune survival. It's a big problem. So you only have the existence from the original spirochetal form. Beside these original, these Borrelia forms, it is well proven that cystic forms are existent and additionally intracellular forms, and that could be also a challenge in treatment. So there's always a general recommendation from US to continue treatment until the patient are symptoms free. I think that is a good recommendation, and so due to the different forms of Borrelia, for example, so the cell wall-free forms, cystic forms, the intracellular forms, we have a huge range of different antibiotics which are able to reach the different forms. Due to this reason, it is from our side of view always needed to combine a minimum of 2 different antibiotics. So we had seen bad experiences only using monotherapy. So a minimum of 2 should be done. So here are some additionally examples. So the combination of amoxicillin, for example, and macrolide of cephalosporins and macrolides together with one of the antimalarias like hydroxychloroquine or artemisia that could be also added, have shown good chances to get rid of the problem. So in general, we have for patients with confirmed chronic Lyme disease, treatment ranges between 2 and 6 months. So very often heard recommendation from US to treat for years, we do not follow. That is according our experiences for the new test systems. So we are now used to get the good information from these cellular testings, and if the patient recovered from all the complaints and symptoms, and we do not see any more activity in the cellular testing, then the point had been reached to quit any treatment. So in general, that could be seen within 2 and 6 months. We have single patients where we had needed a little bit longer time of treatment, but most of the patients recovered latest within 6 months. And to minimize the side effects using these combined or mixed combination, we always ask the patient to use probiotics at the same time, coenzyme Q10, to reduce the negative influences on the mitochondrial system and to support themselves with special diets. So, conclusion for today. Chronic Lyme disease is very often needs an individual treatment regimen. Treatment should include all possible forms and subtypes of the confirmed or highly suspected bacteria. In case of suspected or confirmed chronic Lyme disease patient, should always be double-checked on possible co-infection. The duration of therapy should be guided by clinical response rather than by an arbitrary treatment course. Thank you very much for your attention.
Thank you.